Today, this session will focus in on the patient safety dimension in the competency areas of assessing patient safety culture, identifying and reporting patient safety risks and events, as well as collaborating to analyze patient safety risks and outcomes. So many organizations had to pivot and adapt at lightning speed to deal with COVID, and so many extra steps needed to be taken to keep both patients and staff safe. The trick is sustaining those gains over time and not falling back into old habits as the adrenaline finally begins nonstop for months on end. Watch to see how HQS students use their first-hand COVID-19 experiences to conduct these case studies that discuss the below points. Speed to adoption of COVID-19 safety protocols, infection prevention, daily workflow alterations, maintaining quality and safety of patients, sustaining processes through the pandemic, and adaptation to post-pandemic environment. Now, to introduce our session, we have President and CEO of the Commission on Accreditation of Healthcare Management Education, known as CAHME, Dr. Anthony Stanowski.
5 years ago, CAHME began a journey with leading universities from the United States and Canada offering master's programs in healthcare quality and safety. We joined with top practitioners and organizations, including NACU, to establish the criteria, standards, and core competencies for graduate programs in healthcare quality and safety. The reason why is simple: to ensure that graduates are better prepared to lead in the important field of healthcare quality and safety. The importance is clear. Quality and safety plays a critical role in improving healthcare outcomes. Our 5-year journey resulted in 9 programs certified in healthcare quality and safety. In addition, 3 programs will have site visit this academic year to become accredited. What you'll see today is how well 2 programs, Thomas Jefferson University's College of Population Health and George Washington University, have prepared their students. In particular, the presentations focused on how healthcare needs to, or rather, let me say, is adapting to COVID-19, making necessary changes to enhance the quality and safety of patients. A common theme is how telemedicine helps ensure their patients continue to receive the necessary health care they needed during the worldwide pandemic. I trust you'll be impressed, as I was, at how well these students, these upcoming leaders, present their results, and how the future of healthcare quality and safety is in great hands.
Hi, my name is Dr. Robin Daria. I'm the Director of Quality Improvement and Patient Safety for the Department of Neurology and Director of the Acute Stroke Unit at Thomas Jefferson University Hospital. I'm pleased to introduce myself and my graduate student researcher, Evan Kolesnik. Healthcare quality and safety is one of the most important fields in medicine today. As a clinician researcher who has direct contact with patients every day, employing best practice guidelines and evidence-based process improvements enables us to maximize benefits for our patient while minimizing harm. I began this project, which Evan will be discussing at the start of 2019. Our goal was to decrease the 30-day hospital readmission rate for our cerebrovascular patients by improving transitions of care. When the COVID precautions began in 2020, we had to come up with a contingency plan and had the opportunity to use telemedicine to not only protect our patients, but also our staff, but continue to provide seamless care for our very sick cerebrovascular patients who are discharged home. This offered a unique opportunity to explore not only our intended intervention, but the efficacy of telemedicine as a therapeutic modality. I'm excited to share this research with you and hope that it'll provide valuable insight into an intervention that can be employed in diverse healthcare settings and ultimately reduce readmission rates for our cerebrovascular patients and improve transitions of care and ultimately positively impact functional outcomes. Thank you.
Hello, my name is Evan Kolesnik. I'm a dual degree Doctor of Osteopathic Medicine and Master of Public Health candidate at the Philadelphia College of Osteopathic Medicine and the CAHME HQS certified MPH program at the Jefferson College of Population Health, respectively. I'm going to be presenting my research today on reducing readmission rates by improving transitions of care for stroke patients in the pre-COVID and COVID eras. And my principal investigator is Dr. Robin Daria. So just a little background on stroke. It's caused by an obstruction or an inability of blood to reach critical areas of the brain. The treatment is incredibly time sensitive, and it's really the focal point and the integral part of our systems of care in the United States. Seeing patients within a critical window in order to receive the medications that they need is important for them achieving the best possible healthcare outcomes. About 800,000 events occur annually, so it is an important healthcare issue. And all-cause readmissions, which includes diagnoses other than stroke, account for about $26 billion annually in the United States. And stroke is a huge contributor to that federal spending, with about 8 to 14% of stroke patients being readmitted, depending on the literature source you look at. So in 2012, the Medicare Hospital Readmission Reduction Program was formed as part of the Affordable Care Act, and it really standardized the 30-day readmission rate as a metric for value-based repayment for hospitals. And it's been shown in previous studies that transitions of care, TOC Clinic, which is the intervention that we are employing in this study, has a tangible effect for improving the readmission rate for not only stroke, but other similar conditions. So really, our goal with this study was to explore the impact of TOC Clinic at a certified stroke center, Thomas Jefferson University Hospital, which is in Philadelphia, Pennsylvania. So just to put things in the context of the NAHQ Healthcare Quality Competency Framework, we felt that our study would enhance the continuity of care through better transitions by using this TOC Clinic modality for individuals who are recently discharged from the hospital, that it would improve stroke discharges and the follow-up process, which we really felt was a process improvement. And we felt that it would increase our understanding of the current and potential for hospital performance by using health data and analytics. So just to define TOC Clinic, we scheduled patients for this transitions of care clinic within 21 days of their discharge from the hospital for stroke. And really, the intention of TOC Clinic was not so much for the treatment of their medical conditions as it was in order to help dispel misconceptions and help empower them to manage their own medical condition. So participants were identified using ICD-10 codes, which are assigned to patients based on their diagnosis in the hospital and at discharge. And we chose those that were associated with stroke. Follow-up telephone surveys were also administered to participants for us to better understand the influence of our intervention in terms of building self-efficacy and to understand their perception of the intervention so that we could go through rounds of improvement in the future. So like much of healthcare, our intervention required considerable adaptations due to the COVID-19 pandemic. So we initially started collecting data at the beginning of 2019, and in February of 2020, we transitioned from an in-person only clinic arm to the telemedicine clinic almost exclusively during the pandemic. And we're far from the only people to employ this strategy. About 30% of all Medicare visits are said to have transitioned to telemedicine during the pandemic. And there are distinct benefits to using telemedicine. It allows us to employ time-sensitive treatment and also time-sensitive evaluation of patients. And it has already been proven actually to be beneficial for telestroke, which is a virtual visit with a patient from home who might be experiencing stroke symptoms in order to help stratify their risk and whether they need to come into the hospital. So given that this has already been shown to have clinical benefits for patients experiencing strokes, it seemed like a logical extension that we would transition to telemedicine. It also had the benefit of enabling us to compare the two modalities of in-person versus telemedicine. And we believe that in the wake of COVID-19, telemedicine is going to become a much more prominent part of mainstream medical care. And so it was valuable for us to understand the way that each of these performed relative to one another. So this is just a snapshot of our results over the course of the 2 years of data collection. So our analysis included 194 individuals, 7 of whom experienced readmissions for various reasons, which equates to 3.61% of all the participants. So if you take a look at this bar graph on the right, you can see that this 3.61% figure actually outperforms both the top quartile, which we use as a proxy for national performance data due to a dearth of nationally reported data. We used this top performing data sample, which doesn't necessarily give us a good look of how we performed relative to an average hospital, but because of how TJUH responds every year, we are able to include ourselves in that population, and it is an apt comparison. We also compared ourselves to the TJUH sample that discluded the TOC Clinic patients, and we also outperformed that sample. When we used chi-square comparison, we did not find a difference statistically between our TOC Clinic and the top quartile, or our TOC Clinic and Thomas Jefferson's overall numbers, which highlights the importance of us collecting more data in the future. In terms of comparison between the telemedicine arm, which was our contingency plan arm, and the original in-person intended arm, we actually have some interesting findings. So of the 7 patients who were readmitted, 1 was in person and 6 were in telemedicine, which sounds like a drastic difference, a 6-fold difference, but in reality, because each of these sample sets was close to 100 patients, both of them were competitive readmission rates, and both of them exceeded the performance of the top quartile. Just a couple of reasons that we thought the telemedicine might have performed slightly worse than the in-person. We felt that general healthcare access was probably decreased due to COVID-19 restrictions. So not only access to neurology care, but also to primary care medicine and to physicians who might be following their chronic medical conditions, leading to worse overall health. It's also possible that the patient-provider connection is weakened by this virtual visit modality, that there may not be as much of an influence on patient self-mediated performance. And then it's also possible that we captured additional patients, individuals who otherwise would not have been included in this data set, who may have not been as proactive about their own healthcare needs. But because there wasn't the need for transport and timing, they may have been able to attend these telemedicine visits and therefore were included in our sample set who otherwise might not have been. Again, we found that there was no difference in chi-square between the in-person and telemedicine arms. So our conclusions based on this study was that TOC Clinic does appear to be effective for reducing 30-day stroke readmission rate. And given that 3.61% figure, it probably has clinical utility for a number of different settings. It dramatically outperformed the top quartile, and we didn't even take into consideration a national sample that included hospitals outside of those top quartiles. So it's not even an apt comparison necessarily. We also felt that both the in-person and telemedicine arms are effective means of reducing readmission rate. Even though there was a slight discrepancy in performance, both of them performed competitively, and both individually exceeded that 2-year figure of the top quartile. We also felt that there's an exciting future for telemedicine. It improves access, which is particularly important for individuals who might be in remote rural areas and aren't readily able to come to clinic. It allows for rapid consults, which, as we talked about earlier, is important for things like telestroke consults, conditions that can benefit from being seen right away rather than having to wait in the emergency department and commute to a hospital. It also helps protect from infection, which was particularly important during this unprecedented pandemic. And our long-term hope is that we want to translate our findings into policy at Thomas Jefferson University Hospital, not only in terms of stroke, but also in other similar conditions. We feel that there could be benefits. And these are our references, and we want to say thank you for attending this talk, and we hope that you found it informative.
Hi, I'm Dr. Sabrina Figueredo, Director for the Healthcare Quality Program at the George Washington University. Under the Faculty of Medicine and Health Sciences, we offer 2 degrees, a Master of Sciences, and a graduate certificate in healthcare quality and patient safety. While these 2 programs, they cover 20 competencies related to healthcare quality and safety. To be in line with our mission and vision, we focus on quality, safety, leadership, and evidence-based practice. Our program has been graduating students since 2010, and we are called by CAHME as one of the founding programs of healthcare quality and safety in North America. In addition, we were among the first programs in quality and safety to become CAHME certified, which means CAHME assesses our program, curriculum, and faculty to make sure we are delivering cutting-edge competencies to our students. Speaking of which, our presenter today, Dr. Rafael Torres, is one of our students. He's a physician and the Chief Quality Officer at the White Plains Hospital. He's completing a Healthcare Executive MBA and a graduate certificate in healthcare quality. The work he will be presenting, entitled Use of the Donabedian Model as a Framework for COVID-19 Response at a Hospital in suburban Westchester County, New York, a facility-level case report, was the result of a student team-based activity delivered in one of our courses called Building a Quality Culture. In this exercise, the students were able to conceptualize the work he'll be presenting. Dr. Torres' topic is timely, and he will present a methodology that can be replicated in EDs across various health systems. Having said that, I welcome Dr. Torres, and I hope that you can be inspired by his presentation.
Good day, everyone. I am Dr. Rafael Torres, and I attend a CAHME-accredited Healthcare Quality and Safety program at the George Washington University School of Medicine and Health Sciences. With one class remaining, I am scheduled to finish with a graduate level certificate in healthcare quality and a master's in business administration. As the Chief Quality Officer at White Plains Hospital in Westchester County, New York, this education has propelled my career in quality and safety. Over the next 10 minutes, I want to review a 2020 article my team and I published in the Journal of Emergency Nursing. This piece highlighted our strategic use of the Donabedian Model to maintain quality and safety during the early days of the COVID-19 pandemic in our area. During our time together, I will briefly review our 2020 March timeline, highlighting the rapidity of the unfolding events. The acuity of the events and the need for a shared strategic structure led us to employ the Donabedian Model in our response to COVID-19. In the end, I will highlight several of our outcomes demonstrating how we maintained or improved upon the quality and safety within the emergency department. Our organization is a 292-bed, non-academic hospital situated 9 miles from one of the first COVID-19 epicenters in New York State, if not the country. As a result of our urban environment, population density, and proximity to New York City, we were heavily impacted. Our community experienced its first infection on March 3rd, and within 2 days, our medical staff started becoming ill. As a result, we required an immediate and organized response, despite knowing neither the breadth nor severity of the problem we had or what we would soon encounter. Over the first 4 weeks, infectivity continued to rise until it peaked on April 3rd, and during this month, we worked through long hours and fear as we developed and redeveloped our response. The blue curve highlights how rapidly the virus penetrated our community during the first wave, forcing us to respond just as quickly. Over this period, the infectivity rate of those tested approached 70%. Now that you better understand our growing problem at the time, our strategic vision was simple and focused on 2 issues. First, we needed to maintain the safety for both our patients and our staff. The latter had to be assured that we were working towards maximizing their real and perceived level of safety to keep them healthy and to provide them a level of reassurance to continue to render care. Second, we needed to maintain the clinical and service quality that our community had come to expect and deserve. Although these 2 elements can simply be stated now, it were the tactics themselves that made this strategy successful. The Donabedian Model has been used as a framework for healthcare quality since 1966. The model describes the structure, process, and outcome measures as having a synergistic relationship, each critical to evaluating healthcare quality and safety. Structural measures are defined as characteristics of the space where care occurs, including architecture and equipment availability. Process measures include the delivery of care to patients and the workflows encompassed therein. And outcome measures describe the effect on the health care of a population. The Donabedian Model was used to conceptualize, plan, and evaluate our facility's pandemic response interventions. With this in mind, we decided upon the tactics to employ to meet the two goals highlighted by our strategic vision. Several of our structural changes are listed here. First and foremost, we needed to conserve the core of the emergency department. This conservation entails recognizing and mitigating the risk of unintended exposures between patients, staff, and visitors. There was also a requirement to conserve bed capacity to render care both for the infected and the uninfected. A COVID-19 hotline was created as a community resource to answer questions and help a patient decide whether ED care was warranted. We wanted to keep the worried well at home. When patients did arrive unannounced, screening began in the waiting room before other, more permanent architectural changes could be made. What you see in these pictures is the Western Shelter that was erected, which eventually became the COVID-19 triage location when we sealed off the traditional emergency department entrance, both to visitors and to patients. Within the department, we built walls, sectioning off whole areas, and applied negative pressure to the entire zone, not only individual patient rooms. We also created antechambers, noted in the pictures, where personal protective equipment, or PPE, was donned and doffed to reduce the risk of contamination between these new zones. Knowing that these efforts would not completely mitigate risk, we added an additional layer of protection by standardizing personal protective equipment use across staff members and patients. No one was left unmasked and potentially unprotected, from the clerical staff to patients and everyone in between. This requirement preceded any state or federal regulations. We also developed a telemedicine program to render care at a distance, thereby conserving PPE and removing all exposure risk. Finally, staffing additions were deployed, such as embedded environmental service workers, spotters to ensure appropriate PPE use, and a new critical airway team to provide high-risk care. Within those structural elements previously discussed, we overlaid new processes to continue to mitigate the risk posed to the quality and safety of our patients and staff. COVID-19 screening took place at home via our hotline before a patient even arrived in the emergency department. Eventually, that was not sufficient, and screening had to begin outside the department itself within the Western Shelter. The establishment of a sealed-off high infectivity and high acuity zone focused the team's efforts on contamination prevention and clinical care at the same time. To conserve ED and hospital capacity, we had to send home those who had the potential to become sicker and who may eventually require hospitalization. To mitigate this risk, we utilized telemedicine to render care at home to those deemed to have the most significant risk of at-home decompensation. Those encounters would occur on days 2, 5, and 7 after ED discharge, and provided us the ability to again reach out to our community like we had done so before with the hotline. ED telemedicine visits, as a result, went from 0 pre-COVID to over 800 during the first wave. In addition, PPE spotters and environmental service workers worked alongside the clinical staff, functioning as shift safety officers, monitoring practices surrounding contamination prevention and appropriate PPE donning and doffing. Finally, the designated critical airway team was responsible for the highest risk procedures, They trained with high-fidelity mannequins and utilized fluorescent dyes with black lights to simulate the aerosolization risk during the procedure and during PPE removal. They eventually handled over 50% of the organization's endotracheal intubations, keeping the least experienced out of harm's way. Although time was limited during this period to definitively measure our success, we used several outcomes as surrogate measures for quality and safety. To maintain ED and hospital capacity, as previously mentioned, we needed to send patients home who may have been observed in the hospital during a less dire situation. Our standardized approach with telemedicine mitigated that risk, with 1.1% of patients discharged returning to be admitted within 48 hours of their index ED visit. This outcome is unchanged when compared with data from the preceding months and years. In so doing, we maintained our inpatient capacity to the point that we never had fewer beds than we needed. We used this excess capacity to assist other organizations who are less fortunate by accepting transfers from these facilities. The experience of our patients, although stressful, improved from the upper quartile to the upper decile as measured by Press-Ganey. It's remarkable that our service quality improved during these difficult times, but I owe this achievement to the planning, teamwork, and improved communication. Finally, our staff was less likely to become infected than other community members, both near and far. After the first wave, New York State measured our staff's rate of COVID-19 antibodies to be 11%, and this is compared to the rest of the county at 13%, and New York City, which stood at 20%. In the end, we kept both our patients and our staff safe. A structured, strategic approach to quality and safety using the Donabedian Model can address both traditional problems and those more novel, like COVID-19. In these scenarios, structure and process matter, and when addressed systematically, desired outcomes will follow. Thank you again for joining me today, and thank you to CAHME and the George Washington University for allowing me to share our experiences with you today. Take care.
Hello, I'm Dr. Mary Reich Cooper, Director of the CAHME Certified Healthcare Quality and Safety Program at Jefferson College of Population Health in Philadelphia, Pennsylvania. I'm here to introduce Tony Caldwell, one of the students who's specializing in healthcare quality and safety as part of her MPH program here at Jefferson. Tony is a respiratory therapist, and you're going to hear about her experience this past year with the COVID-19 pandemic and the epicenter at Abington Hospital, which is one of the Jefferson Enterprise hospitals north of Philadelphia. I'm really pleased that Tony has been in our program during this time so that she can talk about healthcare quality and safety from an academic perspective as well as her experiential perspective. Thanks, Tony, for joining us.
Hi, my name is Tony Caldwell. I attend the CAHME Health Quality and Safety Certified Program at Thomas Jefferson University's College of Population Health. I'm here to talk to you today as a respiratory therapist about my experience with COVID at my hospital and my respiratory department. I would talk to you in particular about aerosolized generated procedures and nebulized medications. So nebulized medication is considered an aerosolized generated procedure. It is a procedure that produces aerosolized particles that are small and light enough to remain suspended in the air for several hours and can extend to 6 feet or more. For this particular reason, AGPs pose a great risk to hospital workers, and any hospital worker that enters a patient's room with an aerosolized generated procedure has to wear a gown, gloves, N95, and eye protection. It is preferred that this particular patient be in a negative pressure room, but I know at Abington, not all of our floors have negative pressure rooms, and if they do, we may only have 1 or 2 rooms. So this posed an issue with our patients. So we came up with a new policy and procedure, and this particular policy change was probably implemented throughout the country in most hospitals and respiratory departments. No patient was to be given a nebulized treatment unless they were ventilated. And that's because at Abington, our patients who are ventilated, the nebulizer is put in line in the ventilator circuit. And when medication is administered, it's considered to be a closed system. As far as our patients on the floor, if the patient was ordered for respiratory treatments, the respiratory therapist was to go and assess the patient and determine whether they had a history of obstructive lung disease or if they were in active bronchospasm. These are pretty much the only indications for bronchodilator therapy. If it was deemed that a patient did not have either one of these, then the respiratory therapist was to discontinue the order. If during a respiratory assessment, if they found that the patient did have an obstructive lung disease, or if the patient was in active bronchospasm, and the respiratory therapist was to continue to assess the patient and determine the appropriate inhaler therapy and frequency the patient should receive. There were several challenges to this particular policy, is that respiratory therapists needed to educate the attending, our hospitalists, our residents, and our nursing every day of the change. 2, not all nebulized medications are available in inhaler form. 3, we had to educate the patients on appropriate inhaler technique. 4, not every patient had the sufficient inspiratory pool to appropriately do an inhaler. Typically, if a patient is in an exacerbation of asthma or an exacerbation of their COPD, the appropriate medication is nebulized therapy. And many of our patients who have severe COPD or have very severe COPD, they do not have the appropriate inspiratory pool to effectively do the inhaler. We also found that probably within a week or 2 of this policy change that there was a shortage of albuterol. And at Abington, there was a cost issue. Inhalers are known to be more expensive than nebulized medication. And at Abington, we did not use the common canister technique, meaning that we gave a new inhaler for each patient. We did not use the same inhaler for each and every patient. So this posed a cost issue for the hospital. So for the past couple of months, our COVID numbers have been decreasing. And since then, we have improved our policy on nebulized medications. So now, if a patient does require respiratory therapy, the respiratory therapist still goes in and assesses the patient and determines whether the patient has obstructive lung disease or whether they are actively in bronchospasm. We also determine whether the patient is COVID negative or whether the patient is COVID positive or under inspection. If in fact the patient is COVID positive or the patient is under inspection and they're not intubated, then that particular patient is to be converted to inhalers. If the patient is COVID negative and not under suspicion for COVID, they're not intubated, then it is okay for them to have nebulized medication or inhalers, whatever is appropriate for this particular patient. If in fact the patient is deemed appropriate for nebulized medication, then that patient must be in a room by themselves. This does pose an issue for our patient flow center because often our patients are ordered for nebulized medications and they are cohorted with another patient. So before we give this medication, the patient has to be transferred to another room where they are in the room by themselves before we administer this medication. Once the nebulized medication is administered, the door is to be closed for 1 hour post-treatment, and any hospital worker that enters the room during that particular hour must wear full PPE. I do see that this practice will probably continue as we move further with our COVID procedures. And as respiratory therapists, we will continue to assess our patients for appropriate medication. And I thank you very much for your attention.
Hi, I'm Dr. Mary Wright Cooper, and I am the Program Director for the Healthcare Quality and Safety Program at Jefferson's College of Population Health. Jefferson has been around in Philadelphia, Pennsylvania for almost 200 years, and our Healthcare Quality and Safety Program for more than 10. 2 years ago, we became a certified CAHME program as part of the effort to standardize healthcare quality and safety education across the United States. I'm here today to introduce Veronica Chavez. Veronica is one of our students at Jefferson's College of Population Health, getting an MPH program with a specialty in healthcare quality and safety. Veronica's background and interest is in reproductive medicine, and during the pandemic, Veronica assessed whether contraception visits in family planning clinics stayed the same, went up, or went down as a result of social distancing, restricting visitors to healthcare organizations, and all of the concerns about the pandemic. I'm so happy to have Veronica with us today to talk about her results. Veronica is a student at Philadelphia College of Osteopathic Medicine and took out time to come to Jefferson to complete her MPH and with the specialization in healthcare quality and safety. Thanks, Veronica, for joining us today.
Hello, my name is Veronica Chavez. I attend the CAHME HQS certified program at Jefferson College of Population Health. I am in my final year of my dual degree DO MPH program through Philadelphia College of Osteopathic Medicine and Jefferson College of Population Health. Today, I will be presenting my MPH research entitled Adaptations to Contraceptive Services During COVID-19, Findings from the Society of Family Planning Survey. COVID-19 has had a significant impact on women's lives in the United States. There have been a variety of social and economic stressors that have led women to reconsider pregnancy during the pandemic. Examples of such stressors include job loss, and with that, loss of health insurance benefits, an increased burden of caregiving, either of elderly family members who may have fallen sick or children who were sent home for quarantine. According to data from the CDC, 2020 had the lowest birth rate yet in a 6-year consecutive birth rate decline. So with this all being said, access to contraception was a key public health priority before the pandemic and certainly during the pandemic. However, currently around 50% of US counties do not have a single OBGYN. So there is a dearth of healthcare providers to also offer the appropriate services needed. For methods, I reached out to the Society of Family Planning, a research organization that is dedicated to reproductive healthcare research. During COVID-19, they were able to conduct a longitudinal survey study to assess COVID-19's impact on reproductive health clinics. They were able to collect data at 3 time points during 2020. Time 1 was February through April, time 2 was May through July, time 3 was August through October of 2020. My capstone research aimed to conduct a secondary data analysis on survey responses regarding changes to contraceptive services. And so to summarize, my main questions were: what adaptations were employed to sustain contraceptive services throughout the pandemic? And could these adaptations improve contraceptive services in the post-pandemic era? For the results, SFP was able to enroll 74 clinics across the US for this survey study. All major regions of the US were represented, and survey response rate was 89% at time 1, 84% at time 2, and 82% at time 3. In terms of clinic type, 51% were academic hospital-based centers, 26% were Planned Parenthood, and 23% were independent clinics. In terms of the major clinic adaptations that were endorsed, the most salient items were clinics started or expanded telehealth services for contraceptive counseling, clinics extended existing contraceptive prescriptions for established patients without consultation, and clinics used patient self-report of blood pressure to start estrogen-containing methods. Other adaptations that were endorsed included routine counseling of extended LARC use, offering prescriptions for DMPA, or as it's more commonly known, depot shot self-administration, and routine counseling about IUD self-removal. So this graph shows the frequency with which these adaptations were endorsed at Survey 2 versus Survey 3. What is interesting to note is that by Survey 2, almost 80% of clinics had endorsed the expansion of telehealth for contraceptive counseling. And furthermore, they had also, by time to Survey 2, extended existing prescriptions for established patients without additional consultation. Another data point that was explored was the average volume of contraception visits during 2020. So we have values for the pre-pandemic levels, and then the trend for the rest of the year shows that there was a slight dip at the beginning of the pandemic, but that clinics were able to recover and return to pre-pandemic levels for these visits. And finally, in August through October, there was an actual increase in the volume of contraception service visits. The implications for this analysis include the following. Clinics quickly adapted despite challenges with staffing shortages and health restrictions in order to continue meeting patient needs around contraception. Some of these clinic adaptations expanded the patient's role itself, which, if adopted in the long term, could improve the timeliness and efficiency of patient-centered care in the future. Also, telehealth for contraceptive counseling could be an adaptation that is maintained in the post-COVID era in order to improve contraceptive services. Maintaining telehealth will depend on whether Medicaid and health insurance companies will modify their compensation schema as well. For now, though, this analysis suggests that telehealth could be part of a more comprehensive strategy around contraception services to provide more equitable and timely care, especially in areas that are underserved in the country with little to no reproductive health care access. I'd like to thank you for joining my presentation today. If you have any questions or comments, please feel free to email me. I've also attached my references to the last slide of this presentation. Thank you so much for your time.